Fathers broken hearted, I surely came. Sons that were slain for minimal gain. Youth that can't read, speech that can't talk. Passion to move, a love that won't walk. I speak to you, my heart and my soul. My family and folks who I surely owe. My 100 double O, nigga, ride a flow to the beat.
Hello, and welcome to a new edition of Education is the Best Medicine. And thanks for watching. Remember, community public access is your best bet. Today is a real special show. I want to introduce my boss, the new medical director of Healthy Oakland, Dr. Benny Brown. You know, I always say leadership is a special characteristic. It encompasses understanding, fairness, but a sturdy hand. I think Dr. Brown's experience over the last couple of years, something like 25, 30 years, isn't that right, Doc?
About 30 years.
Yeah, about 30
correct.
years as a physician and OBGYN and administrator has positioned him uniquely to take over the reins of Healthy Oakland at a time in which his skills are sorely needed and very appreciated. I want to give really special thanks to the past medical directors, Dr. Jeffrey Watson and Dr. Ben Littlejohn. Excellent men, excellent physicians, and we want to thank them for all their support. But it's time to move on. Thanks, Dr. Brown. Thanks for coming on.
Thank you.
I want to have you come on, first of all, because this begins at a discussion for me about maybe 5 or 6 years ago when I first met you, and we were at a mental health conference. You were then running another facility at that time. And we just talked about briefly, but from the sense that I got from you, you were always a person that was thinking and intuitive and thinking about change. I was really excited when I found you were going to become a medical director, and we had in-depth conversations, and I wanted to talk a little bit about, one, your background, your specialty, what do you bring to the table as a practicing physician over 30 years in the communities that you've worked in?
Okay. I was born in Vallejo, California, Northern California, and my family then moved to Southern California, to Los Angeles. And at that time, I finished high school in Los Angeles, and I went to UCLA for college. Then I came back to the Bay Area and went to UC San Francisco Medical Center for medical school. And then I decided to go back into the real community, and I went to King Drew Medical Center for my residency in obstetrics and gynecology. Mm-hmm. And after that, I had started a family, so I brought them back to the Bay Area, where I was in private practice in San Jose and a little while in Los Gatos for approximately 15 years. After that, I came to the realization that it wasn't good enough to just say one patient at a time like a private practice does. I had more desire, a lot of desire to start doing community-based medicine, the kind of medicine that the good things you could do, the quality that we could present to different patients would be on a community-wide basis. Mm-hmm. And so I went into community healthcare medicine, mm-hmm. And community health center medicine, rather. And that was the closest thing at the time to being able to really do for the community what you wanted to do. You know, you could do more good than just one patient at a time. You could actually affect the health of a whole community. Mm-hmm. So I spent some time in Central California, which was like another degree in learning the whole concept of community-based medicine. Then I came back to the Bay Area, where I worked at a medium-sized to large-sized community health center in Hayward, California. So it was time to move on to something.
And you're speaking Spanish during that time, too?
Yeah. Well, I've been able to speak Spanish since the 7th grade, and but it's not my first language. So, but it helps. It helps a lot, and especially in my specialty, where a lot of the patients in the past have been Spanish-speaking females. So, but I began to get really interested in the politics of medicine. I began to get really interested and started to study the legal aspects of medicine and then the business of medicine. So at that point in time, that, as I stated earlier, that wouldn't have been a good match for private practice. Mm-hmm. So I had found community health center, and I just call it community medicine. And that was a way for me to be able to use those new gifts I had received as far as learning all those things about medicine. Because the average private practice doctor just is trying to stay above water. We never were trained to be business people. They only talk politics, but they don't really know politics. And they know very little about legal medicine. So that led me to, within the past year, I became really anxious to actually come back into my own community and effect change that way. Like I said, with the skills I had learned over that period of time. So I was given the opportunity to work at Healthy Oakland, and I've been there approximately 6 weeks now. And George is my new idol. So. And we work together so well, we just have like instant communication, you know, our philosophies, what we want to see, what motivated us in this area of helping our community just kind of came together. And so it's more than he'll say, it's like an honor for me to work with him. And I've hired, fired, worked with many, many physicians, mid-levels, but I call all of them just clinicians because the skills of some, you can't just say doctors anymore because a lot of them aren't as skilled as what I consider mid-levels. And in my previous jobs, I actually hired an overwhelming majority of mid-levels to work with me because I respected
assistants
them.
or nurse practitioners? Right?
Both.
Okay.
Physician assistants and nurse practitioners were equally skilled, you know, as physicians in my experience. So most health centers got a bargain because they try not to pay that much to the mid-levels, but I always brought them up to a level that was pretty close to being consistent with physicians, and they always had equal voting rights and political power within the health center because they truly made the health center. The doctors were simply consultants. That's my philosophy.
Would you talk about your view of leadership, particularly as it relates to healthcare and community healthcare? What do you think are some of the challenges as we try to turn the corner with a community clinic such as Healthy Oakland?
Several of the challenges are in an organization like I'll call Healthy Oakland Community Health Center. One of the biggest things is of course funding. And as usual, most African American based entities are usually pushed to the back of the line when people are handing out funding. That's one thing that's an issue. And I think we're going to have some luck as we move forward with the different people who see what things like you and I are doing in Healthy Oakland. I mean, this new philosophy that we're promoting is this basic patient-centered care is, I think we're not going to let it become another fad in medicine because a lot of entities, healthcare entities will grab anything that will make them appear to be up in the times. But now we've entered a field that you truly have to believe in taking care of people, where you truly have to believe that the patient is the center of the whole health center. The patient's needs, patient's desire, they have to have access for us, to us at all times. They have to have access to educational information with respect to prevention. There's a bunch of things that takes place. They have to be able to contact us on a regular basis. So, of course, in the future, we want, particularly in communities like ours, we want them to have something very similar, and hopefully they will have even internet access. But when I say that, I don't mean to surf the internet, but to actually contact us and say, the way we do now, we used to get up and go and make rounds. Now we should round and see what our patients had sent us, maybe messages overnight, and then immediately get back to them. Because we're truly here, our positions are here where we work for our patients. And not just the clinicians, but every aspect of assistance in a community health center. I mean, the referral system, the way we answer the phone, the way we greet, all of that is important. The way we greet the patients, all of that is important in the creation and sustaining of a medical home.
You know, we had, when you originally came aboard, we had talked about this, and I presented some information, you presented some information for me in regards to the discussion around patient-centered care and particularly the home clinic. But one of the things that I'd shared with you that I thought that, again, as you just stated, that the use of these terms and the actuality, what happens to the client, is another discussion. We found that in most quote-unquote patient-centered home clinics, the systems are divided for the provider and for the system. I think we are unique in the fact that we are really trying to approach this from a patient-centered model in which we see the disease through the patient's eyes. You talked a little bit about IT in regards to the electronic medical record, in regards to use of email to contact patients and have discussions, accessibility through phone call, and accessibility of hours is a really priority, I think, as we move the clinic to the next level. Wanted to talk to you about your as we talk about this patient-centered model, I wanted to ask a couple questions about how do you, well, we just defined access to care, making appointments easy and day and time. And again, we are going to be using surveys a lot for this discussion, is our understanding. Right. Tell us a bit about patient engagement and care. And what I mean by that is what you're saying, putting the patient in the center. How do you think that we are going to be able to ensure that our patients feel they are engaged in their care?
Well, you mentioned a real important thing, and that is access to us. Access to, we already talked about access to information. That's very important. Access to us is even more important. That means having an appropriate number of providers available, or of any level of provider to take care of them. That means having hours in the health center that are available. That means having phones to get picked up, and that's very important. One of the most important things to me, happens to be that when they do reach one of us, we really listen, and they hear us also. So that's true communication. So the whole patient-centered health care model says that there's got to be no barriers to communication. And you can't say, well, we have to be concerned about abuse. Well, no. If you have an excellent relationship, a two-way relationship with these patients where they can access you, then there is no problem with that. I think the other important thing is that you have, and the term gets used over and over again, but I think through this patient-centered model, we in particular at Healthy Oakland will want to see, and like I said, I'm almost tired of using this term. It needs to be another one. Cultural competence is the concept. But I'm beginning to kind of personally evolve, because everybody's using cultural competence, and it's starting to lose. We know what it means. We know what we mean when we say it. But it's really being able, I almost want to call it cultural, being able to be culturally relevant in our communications with our patients. And that means they really understand what we are saying and who we are. And then you don't learn that in medical school. You don't learn that in residency. That's got to be something that's been ingrained in you all your life.
Another aspect of the model is care coordination. How do you think that's going to take place, and what form would you like to take place in as we move this model forward?
Well, the care coordination is important too, because what we need, when we mentioned education earlier, we have to make sure when we see a patient, and I'll use an example of someone that has diabetes, we have to make sure that person understands their disease, that they have their appropriate medicine, that they communicate with us, and they communicate with counselors or case managers. See, it becomes a whole new ball of the way we practice medicine, and the patient is at the center. So it's almost like the patient sits there, and if the patient needs this, if he needs something from me, if he needs something from you, if he needs more education, if he needs a better drug, if he needs to have laboratory tests done, all of those should revolve around the patient.
Shouldn't have to think about it or ask for it. We should be on it.
Exactly.
Yeah.
And it'll take people like you and I who have a understanding of what we mean by patient-centered care to do that. So a lot of resources, a lot of counseling resources, housing resources. What you have to do is look at the community of the patients that come to us, and we have to understand that community. We have to tell them to come to us. What do you need? Do they need homes? That's all a part of care. Do they
Food,
need
clothing, shelter?
Yeah, and particular things like mental health services. Now, we have that. It's limited, but it's more than most community health centers in this area have.
And it's a great way of handing off that I'm not used to.
Exactly. And the model has been talked about for years. That was the first model that was called integrated health care. But I think we see integrated health care a little bit more. It means something else now. It doesn't just mean that we have a behavioral specialist available to hand patients off. Like, we're lucky we do. Like I said earlier, most of the community health centers here haven't got that concept. And one of the reasons was that in the past they weren't receiving compensation. Okay, so the health centers didn't want it. If it didn't make money, they didn't want it. But we need to get to a place where we have income coming in from other areas and other services of the health center, and we just can't make money on everything we do. We need to accept that, because we need to do what's right for the patients, what they tell us they need. And some of that we won't receive reimbursement for that. But we have to get to when I say we, I'm talking about people in medicine. They have to get to a point where they're not always looking at that the bottom line is dollars as opposed to quality and efficient patient care.
But, and you and I talking initially, we felt that when I presented Smile to you and we talked about it because you were quite familiar with it, we felt that this was the best model for the organization, that it fit the DNA of the organization.
Exactly.
And that's what we want encompassed in this level of care. We want patient-centered care to be the DNA of our organization. We want the home clinic to be the DNA and the repository for individuals, so they come to their home and they get a place where they are warmed and welcomed. And that, again, gets to the kind of people that we choose and the people that we want to work there. They have to have a real sense of commitment, a real sense of understanding of the issues of trauma and the diversity of our community, and that everyone needs to be heard and spoken to and listened to, whatever those issues are. And too often, as I read it, I think a lot of the systems that have been created for the provider or for the system and not to the patient. And we think this model already exists. You've been doing OBGYN care for a minute. With the discussion around I went through the literature and saw stuff like, discussions around vaccines for human papillomavirus in women and in some men, irregular menstrual bleeding on birth control pills, and also access to, in general, women's health care services. And at one point I thought it was very, very easy access. Now I think we're kind of losing that accessibility. Could you, one, give me a short discussion about about the HPV virus and who you think needs to take it, who doesn't need to take it, and also the discussion around women and general women's health care?
It should be taken, as far as I'm concerned, by young women and young men, and they've decided there are age ranges. And I recommend, if you're absolutely sure that they could not have already been inoculated from sexual intercourse, that they get it. Even though OBGYN today, we have an excellent hold on cervical cancer.
That was the other thing I saw.
Yeah,
Cancer.
it's totally related to, well, over 90% of cervical cancer is related to human papilloma virus. Of course, who can't be diagnosed? As a gynecologist, we can do pap smears and we can do colposcopy, which is a microscopic examination of the cervix. We can do biopsies. So we can pretty much, the overwhelming majority of women can be diagnosed and watched, because a lot of what we do today is we watch them. Unfortunately for men, it's hard to diagnose. It's hard to diagnose in the sense that they almost have no physically visible lesions that can be seen. Okay, so that's even more reason why we should look at the vaccination of men for this particular medical entity. But you rarely have a woman today dying from cervical cancer anymore. We become so vigilant, and we have so many tools we can use for women. But the vaccine would help us a lot because it gets stopped in the early stages. Okay, so
I was asking about your concept of women's health care. For example, when I first started practicing in '82, women's infant mortality of women of color was, particularly African American women, was number one. We, at last time I checked the data, are still number one, but only we having a better educated woman of color that's not be able to get to term in terms of pregnancies. In your experience, have you seen any kind of discussion about why that is? Is it environmental? Is it genetics? Is it trauma? I think it plays a big picture in it, but
I think it's probably a multiple number of things that lead to that. A lot of it is dietary. A lot of it is what kind of stressful environment are these ladies in? Do they work at inappropriate times? One of the big reasons about the whole infant mortality morbidity rate is they have their usual problems we see with people who have a disproportionate share of disparities.
Poverty.
And that is, poverty. They can't get to us. Sometimes eating that, they can have an appointment set for you and I to see them. They can't get there because of transportation issues. Sometimes eating that day is a little more important to come and have Dr. Brown check their tummy and listen to their baby. They don't want to. I'm going back to patient-centered care again. They don't really like their doctors. Their doctors don't talk to them. So you should hear the stories I've heard. Doctors won't look at them. They won't explain to them what's wrong. Yeah, don't want to touch them. And that really upsets someone like me who I love OBGYN, and that's why I went into it from the beginning. But the system is set up to pretty much not allow poor women to get care. I mean, a simple thing like folate in prenatal vitamins, extremely important. Iron, so many of them are anemic, and that's a dietary issue too. Access to a lot of things, and the stress part is significant.
You think some of the issues are intergenerational? Are they from mother to womb to child? Do you see some of the, and just maybe issue around being stillborn or infant mortality? It seems to be you can trace in the line where the mother's mother had it, or did you get a chance to see that kind of family history and these kind of issues, or mostly episodic in that person, that time, that day?
Well, it's both, but a lot of them will follow the lines of heredity. They're hereditary illnesses that are passed down. They say your mother had this. It's very similar to things like breast cancer, where you have to be careful. But that came from a group of people, and I always say, if we got across the ocean like that, You know, we're extremely like superhumans as far as I'm concerned. So why are these descendants of superhumans now having all these problems? And it goes back to poverty. It goes back to no access to health care. But there's an interesting statistic that a lot of people don't know about and they won't talk about, and that's that our premature babies do a lot better. They get stronger. They don't have the deficits in as far as learning disabilities or just mental capabilities, and especially the little girls. Now, of course, the fact that got out, our babies are intrinsically, and especially little girl babies. Why? I've never seen a study on why they think that's true. They'll do better